thank you everybody who's joined today's IASC Inter-Agency Standing Committee briefing on mental health and psychosocial support. Thank you everybody joining from headquarters, joining from the field, joining from the various continents and countries that you're coming from. I'm Tanja Schümer. I'm part of the IASC Secretariat, and it's my pleasure to host you during today's meeting. We know, as humanitarians, as human beings, that emergencies can have significant impact on the mental health and psychosocial well-being of any person, not just on the person himself or herself, but also on his or her family or her or him, his wider constituency. Crises do not just harm one's physical health, but they strip them of their material position and they cause significant psychosocial suffering. This can be the impact can be immediate, but it can also have much longer term consequences for quite a long time to come. And we see this all the time. We see this in our operations, but we also see this here at headquarters where I'm sitting at the moment. In conflict situations, 1 out of 5 people experiences some kind of mental health issues. That's enormous. Those with pre-existing conditions, older people, youth, children, suffer the most, but suffer can anybody and at any time. The IASC understands how critical this topic is, and we also understand how much more we have to do to address this, and that all of us need to play a critical role in doing so. Because of this, the IASC has originally created the reference group for MHPSS, mental health and psychosocial support, and it's a great pleasure to introduce MHPSS reference group's work, both at the field level, but also in terms of guidance today. And we have a very pronounced panel that will help us to better understand what we're doing already, but also what the gaps are and what more there is that we can do. It's really about, this briefing today is about what we are doing, the guidance that we have produced, what it means for you, and for the place that you currently work in, but also how we can help and what other support we can lend to support your work and your contribution to address this extremely critical issue. So I would like to introduce the panelists. We are super fortunate to have with us the 2 co-chairs of the Mental Health and Psychosocial Support Reference Group. That's Dr. Fahmy, and Dr. Fahmy is very big on my screen here. So welcome, Dr. Fahmy. He's a technical officer at the WHO. And then I would like to also introduce Dr. Carmen, who I can unfortunately not see. Dr. Carmen, if you're online. Ah, you're there. Thank you. Great. Fantastic. Yes, sorry, my screen is very much focused right now on Dr. Fahmy. I cannot change that. Anyway, thank you very much for the 2 coaches to join us today. We'll also hear from our field colleagues. We'll hear perspectives from Venezuela and Ukraine, and it's a pleasure to introduce Dr. Alexandra Marcano and Dr. Alisa, and I'm very sorry, I struggle to pronounce your last name correctly, so please introduce yourself when you speak later. They're the co-chairs of the MHPSS technical working groups in Venezuela and Ukraine, respectively. We'll start with Dr. Fahmy and Dr. Carmen Vanetraballero. Brief us on key aspects of the guidance that the reference group has produced on behalf of the IASC, and also on the support that the reference group can lend to field operations. We will then move to our experiences in Venezuela and Ukraine. So Dr. Fahmy, very, very briefly on your background, you're a trained psychiatrist with more than 15 years of experience in mental health and psychosocial support. Mostly in humanitarian emergencies, as I understand. You have served mainly at duty stations in the field, but also headquarters in WHO. And Dr. Carmen, you also have a long time established career in psychology, over 20 years of experience in mental health. You're focused on development and humanitarian work at national, regional, and global levels as a technical advisor for various organizations. So, without further ado, please, the floor is open, and over to you, Dr. Fahmy, Dr. Carmen. Please take the floor.
Thanks so much, Tanya, for the excellent introduction. If we can see our slides, please, and Carmen will start.
Thank you so much, colleagues. Thank you, Tanya. Thank you to the Secretariat for organizing this opportunity today. And we're really happy to have our colleagues joining us to talk a little bit about our work that we do from the reference group. And when we say the reference group, we mean, of course, all of the member agencies that are part of this MHPSS work globally, and that Fahmi and I and our organizations have the pleasure to co-chair. Next slide, please. We wanted to give, just for those who might not be familiar, just give a very brief overview of what is the structure of the reference group. As the IASC Secretariat was mentioning, we are one of the associated entities of the IASC Secretariat. We work very closely to bring together what is happening at the global level and what is happening at the country level in terms of MHPSS work. So at country level, we work through 59 at the moment technical working groups that are established in several countries where emergencies are being coordinated at the moment, and we have our colleagues from Venezuela and Ukraine today to bring up this work from country level. And then from the co-chairs and all of the reference group member agencies, we work together to connect that country level work with the global work of the several humanitarian structures. Just to highlight that at the moment we have 65 full member agencies, 21 observer agencies, and 11 donor organizations, and we work, of course, under the support of OPAC and the Secretariat. Fahmi, over to you.
Thank you, Carmen. And as you kindly mentioned, we have 65 members, and it's amazing that the guidelines is out there since 2007, but this group is still attracting new members. Our most recent memberships that happened during the last 3 months were actually from HelpAge International. We are so proud that colleagues who work specifically on this target population, mental health and psychosocial support, has joined us for the first time. And also RVO, we have a group from the Standby partnership mechanism interested in scaling up mental health and psychosocial support operations, and we will come to our collaboration with Standby partners later in this presentation. Also, it's important, if you go to the next slide, please. It's important to mention that the number of MHPSS technical working groups has increased significantly during the last 3 years. Before COVID-19, we had only 23 humanitarian emergencies. That's less than 50% who are actually having an MHPSS coordination mechanism. Today, we have 59 countries with MHPSS technical working groups. One of the key roles that the reference group play is actually supporting country-level MHPSS technical working groups. Without the reference group, there is no mechanism within the humanitarian system that support and mentor and provide technical support and surge function to these technical working groups. One of the key roles that the co-chairs play is also conducting remote support at the onset of any emergency. We did that with the start of COVID. We did that with the recent earthquake. We did that with the beginning of the current response in Ukraine, and in many other emergencies. This interagency coordination role, remote support, to play a critical role, and also the missions by the co-chair. Consistently, Carmen and I, during the last couple of years, have traveled at least 1 or 2 times every month. We have done 22 missions during the last 24 months, and we focus on missions on strategic engagement with MHPSS technical working groups, whether it's developing an operational plan following the earthquake in Turkey, or whether it's supporting Ukraine at high level, including at the presidential office level and prime minister, and developing an operational map, or it's in doing an MHPSS interagency capacity building. Over to you, Carmen.
Thank you so much, Fahmi. And maybe to highlight as well that this support that we are providing both remotely and on missions, we've also have a very strategic intention in the last couple of years to expand in our capacity to do it in different languages. So we've been covering, of course, Anglophone countries, but more and more Spanish speaking. And we have now a colleague supporting us in the Francophone countries. I was just having a session with our colleagues from Francophone technical working groups providing some training, and of course Arabic speaking. And we really aim at continuing that support in different languages. Next slide, please. So, of course, the support to technical working groups at country level is really, really important. It's the core essence of what we want to do. And if you can imagine, all of the countries, all of those 59 countries right now with technical working groups require much more effort than the one that Fahmi and I can do in our missions. Even if we do many, there's only so many we could do, and only for so long. So it's very important for us to have the capacity to provide more direct support. And this is why we've been very lucky to have, since 2020, a mechanism, the search mechanisms, currently hosted and supported by the Ministry of Foreign Affairs and its agency RVO, to be able to have in a database of more than 200 experts the capacity to deploy colleagues to support these technical working groups. And it's a type of search that is doing that interagency support. So not supporting the work of one or another agency, but actually supporting the coordination role that these technical working groups have. As you can see in the screen, we've done, since its establishment in 2020, 40 deployments, a bit more because in the last few weeks we've deployed a few other colleagues, and most of those deployments have led to either the strengthening of an existing technical working group, or it has led to the establishment of a new technical working group that then the reference group continues to support in the ways that we were highlighting just in the previous slide. Over to you, Fahmi.
Thanks, Carmen. And colleagues, the world before having an interagency mental health and psychosocial support rapid deployment function as the surge we're presenting to you today, I remember back in 2017 when I joined the group as its co-chair, it was only the missions by the co-chairs. While these missions are strategic and are many, but you cannot sustain a functioning rapid deployment mechanism relying only on 2 persons. And we had during the last 3 years 40 deployments. Surge enabled us to reach countries we have not reached before. This was one of the first ever requests for mental health and psychosocial support in emergencies from Chad. It came from the resident coordinator, humanitarian coordinators there, in countries such as Djibouti for the first time, countries such as Niger, Bulgaria, Lithuania for the recent migrant crisis, and also one of the beauties of this mechanism, it starts to build capacities. There are colleagues during the last 3 years who have the function of playing the role of multi-sectoral mental health and psychosocial support coordinators. So it's not only number of experts who are less than the counting of one hand's fingers. It's actually a database now that includes 290 experts with multiple languages in multiple countries ready to be deployed on very short notice to the list of the countries you see. Next, please. So you heard about the remote support function to technical working groups. You heard about the surge function, which serves the field. There is also a normative function, developing consensus-based, evidence-based, high-quality resources for the humanitarian system on mental health and psychosocial support. It's not only the guidelines in 2007, which represented actually a paradigm shift in that field. Actually, the term mental health and psychosocial support itself, which is a very commonly used term now in humanitarian operation, was coined by the 2007 guidelines to avoid confusion in terminology about this area. 2021, we developed a resource to strengthen mental health and psychosocial support preparedness, led now to many agencies, including my agency, WHO, doing actually simulation exercises for the purpose of preparedness, monitoring and evaluation framework that actually enable us for the first time to measure collective impact of this area of work across various sectors. For the first time ever, we addressing in 2022 the topic of suicide and self-harm in humanitarian emergencies, which has been a blind spot for years in humanitarian responses, unfortunately. We have a handbook for mental health and psychosocial support coordination, an area by definition need coordination between health protection, nutrition, camp management, shelter, WASH, and other sectors. And we have also a new minimum service package, inspired by the package that was developed by colleagues who work in reproductive health many years ago, but this time show how mental health and psychosocial support can be predictable, can also be costed, in concrete interventions available in multiple languages that can integrate to emergency response. There are many resources in the pipeline this year, including, for example, MHPSS and peace building resources. The normative function is critical for the IC reference group, and I'm so proud that our resources are among the most translated on the IC website. In fact, some of these usual translations for any of these resources is 20 plus languages, but as we will come later in the slide, some have exceeded that.
Indeed, and how wonderful it is that these resources are very, very used, and we believe the reason why they're so used is because they normally respond to the need that is highlighted by our colleagues at country level. We decide to develop new resources when the needs are identified at country level. Next slide, please. And of course, having these slides produced by the members of the reference group is not enough. They are often, or they are all of them, very operational tools. They're tools to be used and to be managed at country level. So we see the importance to give them a continuation, to be able to offer our support to country level, to be able to implement them. A couple of examples in this regard is, for example, a help desk function that we have to support organizations and technical working groups to implement the monitoring and evaluation common framework. So the colleagues have developed a couple of resources, a few resources to be able to learn on how to use it, but also they are available to consult and to provide technical support. Very similarly, with the minimum service package, which has the nature of being used as what it's been created for, has a number of colleagues supporting this help desk function to respond questions about it, do orientations about it, share the videos that have been created, and even provide support at country level to help organizations using it. Very importantly, we often, you always hear Fahmi, myself, another MHPSS colleague talking about the intersectoral nature of our work. MHPSS is in its nature the linkage with all of the other sectors. We work through health, protection, and all of the other sectors. So we have been working very closely to provide that direct support to colleagues in other clusters, in other sectors, to work together, to respond to technical questions, and to provide that type of help desk function, if you like. And from that collaboration, a lot of very important resources and joint product have come out. So we're very happy with this collaboration. Over to you, Fahmi.
Thanks, Carmen. And the help desk functions is also a way to make sure that we expand beyond the co-chair functions, which actually coordinate the technical support as needed. But you need the collaboration from all the reference group members, and here really comes a symphony of interagency collaboration. The minimum service package help desk, for example, is run by UNICEF, UNHCR, UNFPA, and WHO through some of the most experienced colleagues in this field, and their function is to make sure when there is a new emergency and there is a developmental process of HRPs, MHPSS does not have its own chapter. It has to be integrated across sectors and across clusters. So the help desk would support using the gap analysis tool of the interagency standing committee minimum service package for MHPSS to integrate costed interventions and provide technical guidance to technical working groups. And one example for our collaboration also with clusters, with the health cluster, we run programmatic health cluster clinics where health cluster partners would come to reference group members with inquiries regarding integration of mental health and psychosocial support intervention in health cluster response. We also collaborate with education cluster with Save the Children colleague on a surge deployment for education MHPSS experts, and Carmen and I sit in a steering group that runs this surge mechanism. There are so many examples for this area specifically because our day-to-day operations we usually do with clusters and technical working groups. Next, please. We learned a lot from COVID. We started early, just when COVID was declared as a global emergency of public health concern. And when we started early, we were able to develop wide range of resources. We learned that we need to listen to communities. Most of these resources was developed in collaboration with colleagues in the countries, persons affected, parents. The children's storybook was developed in collaboration with children from more than 120 different countries. We didn't know We didn't expect when we started working back in 2020 that a children's storybook a team of experts, it was around 15 experts from different organizations working on this resource at that time. We didn't expect that this resource would be the second most translated resource ever developed by any structure within the UN, with 145 translations and 60 different adaptations. We didn't expect that it will be among the top 10 translated books in the world. We didn't translate it except into the 6 UN languages, but it was actually communities and countries that kept the demand, and we set a quality checking process. And at the end, it's available in 147 languages and 60 different adaptations posted on the IASC website. Similarly, other resources was developed in consultation with communities, but we learned the lessons. Innovation does not mean always IT. Innovation can be a simple idea that can help and reach communities during the lockdown.
Indeed, and just to finalize, we are taking a bit of time. So just to finalize, to highlight 2 points. What Fahmi was mentioning about the collaboration with the country level, the use of the resources is then continuing. For example, this same year, in response to the earthquake in Turkey and Syria, there's been a beautiful adaptation of My Hero Is You to be used in the context specifically of the fear to aftershocks and so on. So the colleagues at country level keep on using the resources. And if we go to the last slide, we just wanted to highlight that our resources are highly in demand, that we monitor that they keep on being downloaded. Some of the most downloaded and accessed resources of the IASC websites are the resources that we were just sharing with you. And this is for us, of course, it's a matter of happiness and of pride, but it's also important that we continue monitoring because it's the purpose of our resources. And we keep an eye on how much are they being used, because we only produce items and tools that are useful. If they're not useful, if they're not being downloaded, then we need to do a check with ourselves and question again, what is it that is more necessary and more needed. We believe this is, if they are so used, is because of that input that Fahmi was mentioning from, and the methodology that we follow, by which experts work on the resources, country level colleagues keep on giving input, keep on giving their considerations on the uses and how can they be adapted to each of the contexts. And then we've also been working very seriously in looking into what resources that are more visual, more easy to learn, etc., etc. So we hope to continue working in this way, and with those areas of work, supporting country level search, developing on tools, and continue to advocate for MHPSS importance in humanitarian response. This is what the reference group is going to continue to do. Fahmi, I don't know if you have any final word.
Thanks, Carmen. I think this statistics speaks a lot. If during COVID-19, 45% of users accessing the IASC website were looking for mental health and psychosocial support resources, as shown on this Google statistics and the statistics from the website of the IASC. If the most downloadable resource was this children's storybook, I think that's a vote from the communities. If we talk about listening to communities and we want to understand what communities and partners and humanitarians would need, let's look at the IASC website and let's look at the downloads and the statistics. I think communities need more attention to mental health and psychosocial support, and we should continue to do that beyond COVID, and that's one of the key lessons and key messages. Thank you, Tanya, and sorry for taking extra time.
Thank you both. Thank you, Dr. Carmen. Thank you, Dr. Fahmi, for it was a very rich presentation on the broad spectrum of work going on in the IASC and really through the reference group on MHPSS. I would like to pass the floor now to the field and to Dr. Alexandra Marcano, speaking from Venezuela. And just to reassure everybody who is currently participating in this, there will be time for you to take the floor, ask your questions, and share your considerations from where you work and where you live following this presentation. So the next two presentations hopefully will be a little bit quicker, speaking for 5 minutes each. So thank you, Dr. Alexandra. You're a medical doctor. You have worked in remote indigenous communities in Venezuela for over 18 years. You have spent 5 of the last few years developing and implementing health and MHPSS humanitarian programs. And you're currently the Migration Health Officer and MHPSS focal point at IOM, and currently the co-chair of the MHPSS Technical Working Group for Venezuela. Please take the floor.
Thank you. Thank you very much for your kind presentation. And first of all, I would like to express our deepest gratitude to the organizers of the Interagency Standing Committee for the invitation to speak on behalf of our working group. And I feel honored to be among such distinguished panelists. And next slide, please. I will begin with a very brief summary of the context information regarding Venezuela. And after a prolonged socioeconomic crisis for the present year, Venezuela has experienced a slowdown of the economic process. However, this recovery has had a very limited impact on the needs of the most vulnerable, and especially in the health sector. As you can tell, and you can tell that the crisis is still ongoing by looking at the mobility numbers. For every 2 persons leaving, 1 is returning. So that means that there are still more people emigrating. Even though the returnee numbers are increasing, such returns have a seasonal trend. And it is important to highlight that humanitarian financing is declining, coupled with almost absent presence of development sector partners. As of this moment, Venezuela is entering a critical electoral cycle for the next 2 years, and the imposed coercive measures are likely to remain in place. The dialogue process between the government and the opposition is stalled, but it still represents a short window of opportunity to provide political and economic breathing space. And also, regional changes represent an opportunity, perhaps, for further engagement, however, with some limitations. So it's important to highlight that there is an increasing trend of all forms of violence in the country, which is important for our technical working group to understand, especially violence against women that continues to be on the rise, with an approximate rate of 1 femicide every 37 hours. Next slide, please. In terms of the humanitarian architecture in the country, what might be a slight difference from other settings is that in between the formulation of strategic goals and the HRP-specific goals, there is an array of intersectorial coordination spaces that have allowed for an improved integration of these goals into programming, better logic of intervention by improving geographical intersection of the organizations and the implementation itself. And also that allows us to show joint results and foster institution complementarity. Next slide, please. Regarding the mental health and psychosocial support of in Venezuela, different stakeholders have conducted several surveys that are of interest. I'm giving you here a very brief summary. First, the Pan American Health Organization aimed to identify the mental health toll that the COVID-19 pandemic had in the healthcare workers of the region. And in Venezuela, 30% had depression symptoms, but interestingly, only 11% were able to access proper care. In terms of academia, the UCAP University, in their survey, found that 65% of the surveyed individuals stated that the country's economy was a major source of stress, followed by the health system situation. And interestingly, 75% of surveyed people stated that they were suffering from migratory mourning. Several civil society organizations have conducted surveys, and I'm trying to highlight the most important. In terms of education, there's a very slow percentage of reintegration, and since I have very little time left, I'll just jump right ahead to the next slide and tell you that our working group was established back in 2021 then has been gathering data that I'm showing you. I decided to show you just those related to the people reached. And 82% of people reached was through direct service provision, and 18% for capacity building activities. And of those organizations reporting to the 5W, 24% belong to the health cluster, 38% protection, and 38% education. Next. In this slide, you can see, and I'll go very fast because I'm over the 5 minutes now, that we have several partners from civil society organizations, international agencies, and UN agencies. Half of the activities belong to the first two steps of the pyramid, which is good, but I think we need to gather more data because I'm sure there is more people working at the base of the pyramid. Next slide. And to finish, in terms of lessons learned and good practices, we believe the coordination is fundamental for the integration of all levels of the pyramid into one geographic location. I could talk more about this, it's very interesting, but I'm out of time. We believe that we need to foster integration of the MHPSS programming in the humanitarian response programming, and also in the cooperation framework of the Sustained Development Cooperation Framework. Also, that there is a need for rapid training of MHPSS professionals about the implementation logic of emergency and community-based interventions, especially in country settings like Venezuela. We need to increase programs that consider vulnerable elderly and children left behind, and targeting mental health institutions infrastructure is a priority for the country, as well as basic services, focus on the primary healthcare network, avoid medicalization, and focus on community to articulate humanitarian action to peace and development by an area of activities that are stated there to promote social cohesion as a start to improving mental health and psychosocial situation. Thank you very much.
Thank you, Alexandra, and thank you for sharing your perspective from Venezuela. It's so important to hear from field operations. And just to also say, the information shared here, we will share after the presentation on our website. If you want to follow up with our presenters, if you want to dig deeper, you will still be able to do so. I would like to now introduce our last speaker, speaking from Ukraine, and introduce Dr. Alisa. Dr. Alisa, thank you for joining us today. Dr. Alisa is a mental health and psychosocial support expert working with WHO as mental health team lead and co-chair of the Mental Health and Psychosocial Support Technical Working Group in Ukraine. You're a trained psychiatrist with over 17 years experience in mental health. In 2017, you transitioned to public mental health and humanitarian work with WHO in the country office in Ukraine. The floor is yours.
Thank you very much, Tanya and colleagues, and it is a pleasure to be here. First, let me say that we appreciate a lot prioritizing MHPSS high in the IASC agenda, as this is key for us at the country level and for our operations. So let me zoom in you for 5 minutes to the context and situation of Ukraine and our emergency response to the war. First, I would like to say that the war is not the first emergency that Ukraine is facing in past years. We also had, as other countries, the COVID pandemic and also conflict that started in 2014. In the eastern part of Ukraine, but the size of current situation and current war and needs created by it exceeds many times the previously faced emergencies in Ukraine. by saying that, I want to highlight that we started our MHPSS technical working group back in 2015, and with support of MHPSS reference group, we started to build capacity of MHPSS responders, national actors, and start and actually build the coordination mechanism. This next slide. So that enabled to react very fast since February last year when the war started, and with several missions of co-chair of the reference group, we supported the national authorities in launching the national MHPSS program under umbrella of the government and auspices of the First Lady of Ukraine, followed by establishment of interministerial Coordination Council for Mental Health under Prime Minister of Ukraine. And in the end, now we developed specific to Ukraine coordination mechanism, which consists from two parts, which cooperate very well with each other. The first part of coordination is with MHPSS technical working group, and we mostly provide technical support and facilitate coordination of non-government response to the emergency. And also the mechanism that I mentioned under the government umbrella, which is led by Mental Health Coordination Center, covers coordination between ministries within government sector. Please, next slide. So we expanded our technical working group, trying to address various needs, and the organigram you see is informed a lot by the recently published IASC handbook for MHPSS coordination. So, for example, the functions are from the handbook, and I will not go into details, but the structure of the group has multi-sectoral and cross-cutting nature, as we cooperate with health, protection, education, other clusters and their subclusters and relevant technical working groups. We receive guidance almost on a daily basis from IASC MHPSS reference group, and as mentioned, we coordinate closely with national actors. Also, specific situation of Ukraine and various needs that we have, we created by request of partners different task teams covering different thematic areas like stress management, integration of mental health services into primary health care, task team in education initiated together with education cluster. And also we have sub-national level technical working groups, again, as the country is big and needs in different oblasts vary. So we have currently 5 sub-national groups, and also another one is coming and will be created soon. Next slide, please. Another specificity of Ukrainian response is that apart from the fact that needs are very big and high, the response is also very big and complex. So we in the group, we have more than 270 partners, and as confirmed by co-chairs of the reference group, we are now the one biggest group in the world in terms of number of partners and size of the response. You can see this in the map, and of course with following the handbook, we are doing mapping. And you can see here distribution of different activities done by partners across the country. Many partners and such a big response brings opportunities, but also it is a challenge in terms of coordination. It requires a lot of efforts from all of us and all of partners working from the government side of things and from non-government side of response, and we try to do our best to decrease duplications and arrange response in a meaningful way, so we address the needs when it is needed and by activities required, particularly in this case. Next slide, please. So to do that, and informed by their IASC guidelines on MHPSS and emergencies and MHPSS minimum service package, and with support of the chairs of the reference group, we developed together with the government and all the partners in Ukraine the roadmap for prioritized multi-sectoral MHPSS actions, which has a set of actions in each sector, like health, education, mine action, child protection, and many others. Set of priorities for immediate response and also longer term response, and informed by the vision of national authorities and partners what needs to be prioritized and implemented in Ukraine as a part of this response. And last slide. With this, I would like to thank you for the attention, and again, thank you for this important event, and open for any questions. Thank you, and over to you, please, Tanya.
Thank you so very much, Dr. Alisa. I would like to open the floor straight away to questions from participants. The floor is open. You have already shared some in the chat. Please continue doing so, but also please use the hand function within Teams if you wish to speak. Anybody wants to step forward? Maybe already we have one question already from the floor on Ukraine. So we have one question to you, Dr. Alisa. There's a question if it is planned to establish an MHPSS technical working group in Vinnytsia, or whether they would fall under the already established working group. Maybe you want to already answer that.
Yeah, thank you for this question, and we're indeed in process of creating it, and soon we'll come back to partners and discuss this, as we received several requests from partners, and there is initiative from partners, and they also already meet and start to communicate and discuss topics in Vinnytsia. So we're considering as a next step creation of this subgroup. Thank you. Over.
We have another question from Kristen. What is the best way to connect with regional technical working groups in Ukraine? And maybe you can also comment a little bit on the role of local responders in Ukraine providing mental health and psychosocial support, and how others working outside of Ukraine can support that. Over to you again, Alisa.
Thank you, Tanya. I'm not sure that I got the question fully. If you can please specify.
Okay, one question was, what is the specific role of frontline responders and how can we support them, providing support on mental health and psychosocial support? And the other question, what is the best way to connect with regional technical working groups in Ukraine?
So answering the first question, I think what we are doing now and plan to continue and scale up that is to build capacity of frontline responders, so they are equipped well to provide MHPSS to the affected population. And as one of examples that we recently did, and Fami mentioned the workshop simulation exercise that we did in Kyiv for MHPSS response, where we had more than 60 participants. And apart from events that we do for capacity building, we also provide routine technical support and trainings in many areas like stress management and many others. And how, answering second question, how the groups within Ukraine can cooperate with each other. I think this is exactly the main question, and the structure of this and division of the group to national and sub-national reflects the diversity and size of the country, as every oblast is very unique in terms of needs and response and responders available there. So it was driven by the nature of the needs and response that we created these subgroups following requests from partners. But also we tried to do our best so all these groups coordinate well with each other. For that, we have system of focal points, and we support this system from national level, and we are aware of content of every meeting and exchange this information. And during the meetings of the national group, which is umbrella for all groups, we share updates. So everyone from every group is timely updated on all news coming from the national level, and also they exchange this information between regions during the meetings with news from oblast level. Thank you. I hope I answered the questions.
Excellent. Thank you, Dr. Alisa. I have one question for Dr. Alexandra in Venezuela. Can you maybe explain a little bit further what are some of the other areas that require further work, further collaboration, and how we can support that from outside of Venezuela?
Thank you for your question. Well, I would say that we need to work on advocacy for specific MHPSS resources. Perhaps saving a part of the funding explicitly for MHPSS programming would be important. In terms of at the local, at the country level, we need to work on the updating of the legal framework and advocacy also for tailored public policies aiming at specific needs. I would also say that programs and funds should allow us to intervene on the health infrastructure that's underfunded, has deteriorated over the years, and has compromised the capacity of to care for people at the top level of the pyramid. Also, focalized approach for specific groups, such as indigenous, adolescents, as you can see in my slide, people with disabilities, elderly, people on the move, and people left behind, like specific programming for this. And also standardized protocols.
No,
Sorry,
no
I think
sé. Sí.
There's someone with the
Sí, no sé qué hicimos.
Oh, yeah. There you go. Standardized protocols in coordination with health authorities and civil society organizations and academia that working together to streamline MHPSS programming in the sense that we all understand, with a focus on community interventions mainly. Thank you.
Excellent. A couple of more questions, one to all four of you actually. What are the main challenges coordinating collaborating across the work on mental health and psychosocial support? Then a specific question.
We also have a hand up.
We also have a hand up. There was one specific question. How are technical working groups working with the humanitarian clusters, in particular the one on health and protection? Before you answer those questions, can we go to the colleague who has put his hand up?
Please feel free to unmute.
Good afternoon. My name is Vincent Cato. I work for the European Commission in DG Home Affairs in the integration team. Thank you very much for the very interesting presentations. My question was related to your work in Europe. You mentioned the support you provided in a few European countries like Lithuania or Bulgaria. And just to be sure, does this relate to mental health for the support to the mental health system in general, or was related to provision of mental health support in relation to the management of arrival of migrants in those countries? If so, do you think that other member states, have you received other requests from member states, or would you envisage that other member states in the EU would need such support? Thank you very much.
Thank you very much for your question. Any other hands? Yes. Then
we have a hand from
Dr. Fami. Maybe Dr. Fami, over to you.
Thanks. Let's respond to the specific question of our colleague Vincent, and thank you for raising this important point. No, our mandate, like the IASC, our mandate is humanitarian. So we would not respond unless the situation is identified as an emergency, and to specify. But we don't necessarily respond only in clusterized emergencies. Means that we can respond to an emergency where there is a migrant and refugee response identified by other agencies, and not necessarily there are clusters active, but there are sectors. In Lithuania, it was the emergency that happened between December and January of last year, of the migrant crisis between the Belarus-Lithuanian borders. That was specifically the requests that came, and that was specifically what we tried to respond to. One of the co-chairs specifically went there because that was a strategic engagement in a very challenging situation at that time. Bulgaria was for the migrants' response based on a request. But I have to say that the Ukraine emergency has created attention from many of the European member states, including to other emergencies they would have, such as the one in Lithuania and such as the one in Bulgaria, and such as the requests we had from Poland, which were specifically to Ukraine. I think Ukraine was an eye-opener in humanitarian emergencies to the mental health and psychosocial support needs, similar to what we saw with the public health emergency of COVID-19. So despite their tragedies, sometimes emergencies can become an opportunity for this neglected area to come a little bit higher on the policy agenda.
Thank you, Dr. Fami. Over to Aman with a question.
Hi, thank you so much for such a nice presentation. Actually, I am here from Pakistan, working with the UNHCR sub office, Peshawar. Here, I would like to just ask the person who presented, Elisa ma'am, who presented in context of MHPSS service in context of Ukraine. I would like to seek the guidance whether, like here in Pakistan, we too face this similar situation because a migrant from Afghanistan are usually, they are suffering from these mental health activities, and COVID, we were fortunately provided with a fund to continue this kind of activities. But like in Pakistan, the problem is that WHO is more focused on the polio prevention than on leading many other sector groups, many other leads. So like, is there any guidance that without WHO, any agency might be taking lead on the MHPSS focal group? Because in Pakistan there is no MHPSS focus group at the, not even at the provincial level, and even not even at the country level. Thank you.
Thank you very much. Dr. Carmen, over to you.
Thank you so much. My hand was to respond to another question, but I think I'll take the opportunity to respond to you, dear Aman. Thank you for this very important question. I work for the IFRC, not for WHO, but I just wanted to highlight that Pakistan is indeed a very complex country. As you very well know, it's been so big. What the problem, the difficulty that we faced is the establishment of a national technical working group that will be able to cover such a diversity of emergencies, different types of crises, and such a large community. So right now, actually, we have a deployment that, partially answering your question, is actually hosted by UNICEF. So of course, technical working groups can be called by any agencies that are responding to MHPSS. So in different countries, we have different colleagues. It could be normally it's a UN agency and an NGO, but it could take many other formats. It's more a matter of who has the capacity. And it's also interesting that in many countries it rotates, because it takes a lot of effort to coordinate. And normally it's a function that is done in a multi-tasking way. The coordinator is doing other work and then coordinating. So it's important that agencies share the burden in a way of coordination, and that the technical coordination group has functioned through all of the agents. So a short answer is a yes, it can be, of course, any other agency. And in the case of Pakistan, for example, is right now UNICEF, who is collaborating with WHO to look into what would be the best ways of having technical working groups. At the moment, we're working in the establishment of a group in Karachi. So then we can test what would be the best way of coordinating that group, and for them moving to see how many regional, sub-regional groups can be done, because it's important that in such a large country, we work more from the regional perspective than the national one. So we will continue updating colleagues on what is the establishment of those groups, and we're really grateful to see that collaboration between UNICEF, IOM, and WHO right now in trying to identify the best mechanism. And we have a search deployment that will definitely be developing this. So hopefully good news soon. But the important answer is that the coordination is not sitting in one agency specifically or another. It's a joint effort of agencies, and whichever agency has more capacity to co-lead, then that's what they're doing. Yeah, thank you. I don't know if that answered your question.
Dr. Fahmy, do you want to contribute as well?
Thanks. I want to contribute to responding to this question, and also share some reflections on the question on challenges. Aman, this is a great question, and since I'm sitting in WHO in Geneva, I thought I would raise my hand and share with you. WHO contribute to all the guidance developed by Interagency Standing Committee, including the guidelines from its establishment. In none of these guidance, we say that the health sector should lead mental health and psychosocial support group, or MHPSS technical working group should be under the health sector or initiated by the health sector. MHPSS technical working groups, by definition, in all the IASC guidance, including the handbook of MHPSS coordination, the IASC guidelines, are cross-cutting groups. They are not under one sector. They are not under one, just like the cash groups, for example, in emergencies. They are not under one cluster, not under one sector. In good humanitarian practice, I want the education to play a big role in MHPSS, nutrition to play a big role, protection with its sub-clusters such as child protection, GBV, and health. So all of them have a role to play, and the MHPSS technical working group is the place where all these actors come together. So I think it's a common misconception I have seen in this field, that this is under health, but actually this field, whether it get pulled towards health or get pulled towards protection only, or get pulled towards education only, that's where people suffer, because a young student in a school in Afghanistan, she might have nutrition needs, she might be sitting in shelter, she might have mental health needs, and she need all clusters, mental health aspect, to be collaborating and need a good referral mechanism. And the only place you can do that is through an MHPSS technical working group. Aman, actually, there is an MHPSS technical working group at national level in Afghanistan, and I shared you my email and the MHPSS reference group email, which is based in Kabul, and can share with you the contact details of the co-chairs of the MHPSS technical working group in Kabul, and link you with actors there.
Dr. Alisa,
Yeah,
maybe you also want to come in
so
on
much.
questions.
Thank you for the response, and I'll share my email with you, Doctor.
Excellent. Dr. Alisa, did you also want to contribute?
Yeah, I would add a few words on challenges, as we also facing those. And from our side, I would say that the size of the response, as mentioned, and also number of partners engaged creates coordination challenge that we try to address, but also another very interesting thing that that we consider as a little bit a challenge, that contextualization of partners' efforts, as we had the big effort from the national authorities in introducing mental health reform in the country. And a lot of interventions were introduced, a lot of steps taken, and sometimes probably due to lack of time, this is not always considered as a part of emergency response, and we think it should be considered more, and we work with partners on that. Thank you, and over.
Cool. Excellent. Then, Venezuela, can you also still take 1 minute to reflect a little bit on the discussion and what we've heard today?
Yes, of course. I agree that it is a challenge for the whole sector, the humanitarian sector, to understand the logic of integration between health protection and education and other sectors into MHPSS, and that has also been a challenge in the country. But also, I would like to highlight what I already said in terms of specific funding. We also have to continue to work with donors to advocate for specific funding towards MHPSS, which some of them are already doing it, of course, without any question. We've had the opportunity to allocate some funding to specific MHPSS interventions. And in terms of the articulation between sectors, in our country, these intersectoral spaces that have been created at the highest level of coordination have been fundamental to streamline cooperation between sectors at the field level. So that has been a good practice in our country. Thank you.
Thank you. Dr. Fahmy, Dr. Carmen, any final reflections on what you've heard from others?
Go ahead, Fahmy.
Thank you, Carmen. Thank you so much. You're very kind. I heard before one colleague who worked as a protection cluster coordinator. He told me that he considers that mental health and psychosocial support in his operation as a good litmus test for interclusteral collaboration. He told me, if I look at an emergency and I want to look into whether intercluster collaboration actually working well, I'll look to mental health and psychosocial support, because that's a prototype for an area which you cannot go ahead without the collaboration across various clusters. I would add to the challenges rightly identified by Alexandra and Alisa. that we still need to justify mental health and psychosocial support. For us as mental health and psychosocial support actors, it's obvious, it's needed, it's common. We see the suffering, we see the need of the population, we get asked for help. But sometimes we go to an emergency and we face a perception that humans need only water and food and medication, but mental health and psychosocial support is less prioritized. I think what we need to do is understand that this area is a human rights, not luxury, and humans to be able to cope with emergencies require mental health and psychosocial support as an essential component of any emergency response in any sector.
Thank you, Carmen. Any last?
Just to very much echo Fahmi's word, and Alessandra and Alisa, thank you so much for bringing us the important work, which is the one happening at country level. Maybe that would be because what Fahmi mentioned is exactly my words. I would just mention the importance to keep all of these technical working groups in the forefront of our advocacy. They are doing the work. That MHPSS work happening at country level throughout all of those clusters. The essential work of the technical working groups comes along that difficult coordination among all of the different clusters and sectors. Without a technical working group, it will be very difficult to coordinate what our education colleagues are doing for the MHPSS of children in education programs with what is happening in health and protection, etc. So that common place of coordination is very important. And I will back to 59 technical working groups. We're talking Americas, Africa, Middle East, Asia, and of course Europe. So maybe to bring one final work to reach out to them. If you or your organization is working at country level and there is an interest in implementing MHPSS, or there are resources to do programs on MHPSS, reach out to the technical working groups to make sure that we work in a coordinated way, to make sure that the mappings of who is doing what is up to date, and that the technical working groups colleagues can guide and find the best use of all of those resources. And of course, a final word to look at that global perspective at the moment, to use the wonderful example that we've seen today in these two countries, to remember these many countries where emergencies are now chronic, and then we need to continue working in all of them. I think we've all experienced during COVID the MHPSS needs in our own bodies, and this is why it became such a global aspect, because we all understood the impact in our well-being when something is happening around us. So if we take that same experience that we had and we bring in to emergencies, whether they are related to climate crisis, to conflict, migration, and so on, we can definitely understand the need. So reach out to us. I'll put the email address of the reference group once more in the chat. Reach out to us for anything that has to do with MHPSS work at country level, and hopefully we can continue to join forces for the benefit of the communities we work with. Thank you so much.
Thank you. Thank you very much to all our presenters, and thank you to everybody who joined our briefing today. If there are no final questions, then sorry, Alisa, would you like to still come in?
Just thank you for the opportunity, and that was a very fruitful event. And over to you, Tanya. Thank you.
Okay, then great. We have heard about the exceptional work undertaken both at the global level and at the country level by the reference group on MHPSS. We've heard from from both Venezuela and Ukraine on some of the work that is being done at country level, but also on the challenges that still exist. And looking ahead, I just want to reinforce what Dr. Fahmi said just now. We need to move away from the perception that MHPSS can affect people and can be met through just the health system alone. As humanitarians, we all need to contribute to it, and we all need to ensure that we collaborate across the silos, across the various work streams within the IASC and with partners beyond the IASC, so that we not just train our staff to respond to MHPSS health challenges, but also that we integrate MHPSS within our programs. It's really crucial that we take the other step and do even more than what we're doing already, to address this issue, which is not going to go away, but it's going to probably even grow as more and more crises pop up across the world or intensify. And as many of the crises that we work in are protracted and really place a heavy burden on humanitarian workers. So once again, congratulations to the reference group on MHPSS. You're doing exceptional work. Keep up the work. And let us know if there's anything else that we can do from the IC Secretariat, from other IC bodies, and to help also strengthen the synergies and the collaboration between the various IC structures. Thanks everybody for joining this briefing today and for your commitment to the humanitarian work at large, but to MHPSS in general. Just to let you know again, this briefing was recorded. We will share it on our website. You will also find further presentations and further guidance and further work on MHPSS and the various other work streams of the IASC on the website of the IASC. Thank you again for sharing. Thank you for joining, and speak to you soon.
Thank you, Tanya.